Hi everyone, this is Miss Sheridan from Georgia Northwestern Technical College. I'll be doing your lecture today on Chapter 7, Nursing Care of the Woman with Complications During Pregnancy. Complications can occur during pregnancy that can threaten both the fetus and the expected mother. It can lead to a disruption of usual roles, lead to a lot of stress, and especially if the mom gets put on strict bed rest, she may have to find alternate child care. It can lead to financial difficulties and also delayed attachment to the infant. The first complication is hyperemesis gravidarum. So nausea and vomiting, also known as morning sickness, is very common during the first trimester of pregnancy for many. But if nausea and vomiting interfere with an adequate intake of fluid and food and or persist past 20 weeks of gestation, it is termed hyperemesis gravidarum. Hyperemesis gravidarum is a condition characterized by severe nausea, vomiting, weight loss, and electrolyte imbalance. Contributing factors are the elevated hormone levels and the relaxation of smooth muscle that causes delayed gastric emptying that leads to those GI symptoms. Mild cases are treated with dietary changes, rest, and acids. More severe cases, though, are often requiring a stay in the hospital so that the mother can receive fluid and nutrition through an intravenous line. The woman with hyperemesis gravidarum is at increased risk for preterm labor, poor placental perfusion to the baby, and inadequate oxygenation to the fetus. It can lead to a small for gestational age infant. Other complications like preeclampsia, placental abruption, we'll talk about both of those later in this chapter, as well as electrolyte imbalances. So before we jump right in with signs and symptoms of hyperemesis gravidarum, which I am going to abbreviate as HG, and you actually will see this abbreviation sometimes in charts. We'll call it HG. Morning sickness, this is nausea sometimes accompanied by vomiting. With HG, nausea is accompanied by severe vomiting. With morning sickness, it typically subsides, but with HG, nausea does not subside. It lingers. Morning sickness is vomiting that does not cause severe dehydration, but with HG, the vomiting is leading to severe dehydration and fluid and electrolyte imbalances. With morning sickness, it's vomiting that still allows the woman to keep some of her food down, but with HG, a lot of the times the vomiting does not allow her to keep any food down. Signs and symptoms of hyperemesis gravidarum. You'll see things like vomiting multiple times throughout the day with a poor appetite, weight loss to where she may even lose greater than 5% of her pre-pregnancy weight. You'll see signs and symptoms of dehydration such as dry mouth and skin, poor skin turgor, so it might be tenting rather than elastic. You'll see concentrated urine because the body's trying to conserve as much fluid as possible because it's still trying to give perfusion and oxygenation to the fetus. You can see decreased urine output, elevated heart rate, and alkalosis from loss of hydrochloric acid, which is the acid in our stomachs. And that's going to result in a lot of electrolyte imbalances in this woman. So as far as medical care goes, most care for HG may be provided in the home, but some women are going to require hospitalization for IV fluid administration, antiemetic medication. They use safe antiemetics during pregnancy, such as Reglan, cyclizine. You may see acupuncture and acupressure being used to help treat the nausea and vomiting. They'll take an array of laboratory values like the CBC, electrolytes, ketones, and liver enzymes. So the CBC is going to monitor for signs of infection and dehydration. They'll take a panel of electrolytes to monitor for imbalances that are caused by that dehydration. They will look for ketones to monitor the use of fat stores to provide energy to the mother and the fetus, and liver enzymes to monitor liver inflammation. Nursing care of the pregnant patient with Hyperemesis Gravidarum includes administering those IV fluids and antiemetics, monitoring those laboratory results and reporting any abnormals to the doctor, monitoring for weight loss, providing psychosocial needs by referral as appropriate, and allowing time to therapeutically listen to the patient's concerns. For patient teaching, you're going to teach her to do all the following. You want to teach her to eat small, frequent meals rather than 3 very large meals throughout the day. Avoid spicy and fatty foods. Identify and avoid odors that may trigger her nausea. Teach her to sip liquids throughout the day to avoid dehydration rather than gulping. Gulping liquids down very quickly can trigger the nausea even more. Monitor the signs of dehydration that we covered on that previous slide, and make sure you teach her those as well so that she can recognize and report those. Notify her healthcare provider if she notices the following warning signs, and that is dark urine with bloody vomitus, abdominal pain, dehydration, the lack of urine output for 8 hours, inability to keep food down for 24 hours, and noting ketones in the urine. You can teach her to use urine dipsticks to monitor for ketones at home if she's at home. So with ketones in urine, those dipsticks test for ketone levels in the urine. So normally your body burns glucose or sugar for energy. And if your cells don't get enough glucose, your body burns fat for energy instead. So that produces the substance called ketones, which can show up in the blood and the urine. The term abortion is used to describe a pregnancy loss or termination prior to the fetus being viable at an age greater than 20 weeks or fetal weight greater than 500 grams. Spontaneous abortion is also known as miscarriage, which is the most common type of pregnancy loss. It occurs in approximately 10 to 20% of all clinically recognized pregnancies. Spontaneous abortions are classified according to the symptoms and the outcomes. We're going to talk about these different classifications on the next slide. For your upcoming exam, it'll be important that you are able to recognize the different classifications of spontaneous abortions. We're going to cover those here on this slide. The first one is called threatened abortion, and this is when your body is showing signs that they might miscarry, and it's called a threatened miscarriage or threatened abortion. She may have a little vaginal bleeding or lower abdominal pain, and it can last days or weeks, and the cervix is still closed. The pain or bleeding may go away and can continue to have a healthy pregnancy and baby. So the woman may or may not lose the fetus with a threatened abortion. You know, there is a chance that things might get worse and she goes on to have a miscarriage, but there's rarely anything a doctor, midwife, or the patient can do to protect the pregnancy. Inevitable abortions. These can come after a threatened miscarriage or without warning. There's usually a lot more vaginal bleeding and strong lower stomach cramps. During the miscarriage, the cervix opens and the developing fetus will come away in the bleeding. So this happens when the cervix dilates and amniotic membranes rupture. So here the fetus and the placenta are expelled unless the healthcare provider can intervene. Incomplete abortions. So sometimes some pregnancy tissue will remain in the uterus, and vaginal bleeding and lower abdominal cramping may continue as the uterus continues trying to empty itself. This is known as incomplete miscarriage. The doctor or midwife will assess whether or not the woman will need a short procedure called a dilation of the cervix and curettage of the uterus, known as a D&C. It might be necessary to remove any of the remaining pregnancy tissue. It's an important medical procedure done in an operating room. So this occurs when some of the uterine contents are expelled, but not all. So the retention can lead to uterine bleeding and cramping. Complete miscarriage. So this has taken place when all pregnancy tissue has left the uterus. Vaginal bleeding may continue for several days. Cramping pain, much like labor or a very strong period pain, is very common, as this is the uterus contracting to try to empty itself. If you have miscarried at home or somewhere else with no healthcare workers present, you should have a checkup with a doctor or midwife to make sure the miscarriage is complete. So a complete abortion is when all uterine contents are expelled. So when the abortion is complete, its uterine cramping and bleeding stops without interventions. A missed miscarriage or a missed abortion. So sometimes the fetus has died, but it has remained in the uterus. This is known as a missed miscarriage. Sometimes she notices a brownish discharge. Some of the symptoms of pregnancy she might still notice, like nausea, tiredness, might be a little more faded than normal. You might have noticed nothing unusual. So a missed abortion occurs when the fetus dies during the first half of the pregnancy. The fetus is not expelled, and the woman carries the fetus until a spontaneous abortion occurs. Signs and symptoms of bleeding disorders of early pregnancy include lower abdominal cramping and vaginal bleeding. Medical care is including, if the bleeding doesn't stop after a spontaneous abortion, a procedure called a dilation and curettage may be necessary. This is called a D&C. And the D&C is a surgical procedure where the cervix is dilated and that physician gently scrapes the lining of the uterus to remove the products of conception. There's another common procedure that's called the vacuum extraction that may be done, and it's where they take a cannula and attach it to a suction device, and they remove the products of conception that way. So these procedures will usually stop the bleeding on their own. Sometimes they may need a little additional help by using medications. So there's certain ones that help stop bleeding, and that's oxytocin. It's also known as Pitocin or Methergin. So those medicines cause uterine contraction, and they help stop uterine bleeding. So that is oxytocin and Methergin. Your nursing care for your patient who had either a planned or spontaneous abortion includes, so for a threatened abortion, you want to instruct her to avoid sexual activity, tampons, douches, strenuous exercise. She needs to follow her doctor's instructions on when it's okay to resume those activities. You definitely want to monitor her vital signs, her INO, intake and output, O2 sat, and lab test results. You're looking for things as her nurse, you're looking for hypovolemic shock. That should be in the back of your mind whenever there's a lot of blood loss with hemorrhage. Hypovolemic shock is a complication. So that can lead to decreased blood pressure, increased heart rate, clammy skin, also pale color, lightheadedness, and confusion. Anticipating the need for IV fluids, so make sure she has a good patent IV site that works well, just in case she needs some IV fluids. Also, it's very possible she might need a blood transfusion, so I would make sure she has that large bore IV in, so that if she needs that blood transfusion, she can get it very quickly. She doesn't have to wait and be stuck for an IV. So a large bore IV would be like a number 20 or a number 18 gauge. So that's for a blood transfusion. You need a larger size needle. Also, you would want to anticipate oxygen therapy for this woman. I would make sure that she has oxygen set up, just in case, especially if she's lost a whole lot of blood. Those red blood cells carry oxygen. So with her losing all that blood, she's going to need some supplemental oxygen during that time. Remember, you got those medications that we mentioned per the doctor's order, such as oxytocin or Methergin, and that's ordered to help control bleeding. So you would want to teach her about those meds if she is to be getting those. And it's really important that you administer RhoGAM. This is very important to an Rh negative woman who has experienced either a planned or spontaneous abortion or an ectopic pregnancy. So if the Rh negative woman gets pregnant after one of these events, like after she's had the miscarriage, for example, and she has not received this RhoGAM treatment, it's dangerous, because if that woman should get pregnant again in the future, her future fetus may be at risk of problems if it's Rh positive. So it's really important that you administer RhoGAM to the woman if she's Rh negative. And that is within 72 hours. You got to give it in that certain time frame to help prevent isoimmunization. And that means, this word just means like the antibodies building up in the woman's immune system. You know how we talked about in one of the previous chapters how the mama builds up antibodies against the Rh positive baby, and when she builds up those antibodies, it can attack the baby's red blood cells. Well, that's possible that it can happen in the future if she gets pregnant again, if she wasn't treated properly with RhoGAM within 72 hours after she has had either a planned abortion, a spontaneous abortion, or an ectopic pregnancy, something of that sort. You want to make sure she gets her RhoGAM treatment and that you teach her about that. And it's going to be big to provide psychosocial support for this woman. Just being there for her, listening to her, allowing her to ask questions, and just giving her time to collect her thoughts. And sometimes it just means sitting in the room with them. Sometimes it may not even be having a conversation. It may just be sitting quietly, offering your support and your presence for her. You know, it's very normal to go through a grieving process with this, and every woman is different as far as how long, you know, it takes to get over this grieving process. And some women may never, you know, and it's just your job as a nurse to be very caring, be a good active listener, and take your time with her. Sit down with her if she needs somebody there to comfort her. An ectopic pregnancy occurs when the fertilized ovum implants outside of the uterus. Most ectopic pregnancies occur in the fallopian tube. However, they can occur anywhere outside the uterus. So it's the fertilized ovum implanting outside the uterus. Typically, it occurs in the fallopian tubes, but it can occur anywhere. There are certain risk factors for ectopic pregnancies, and they include scarring of the fallopian tubes or a blockage in the fallopian tubes. And those can slow down the movement of the fertilized ovum. Also, advanced maternal age, reproductive anomalies, a history of fallopian tube surgery, a history of pelvic inflammatory disease, repeated induced abortions, repeated sexually transmitted infections, intrauterine devices or IUDs, a history of assisted reproductive technology, and a woman who douches regularly. Also, women who smoke. Signs and symptoms of an ectopic pregnancy include vaginal bleeding and abdominal pain. However, if the fallopian tube ruptures, you will see additional symptoms occurring, like more severe abdominal pain, shoulder or neck pain, and that's due from the blood leaking out of the fallopian tube into the abdomen, and it starts to irritate the diaphragm. She will likely be weak and dizzy, have a decreased blood pressure with an increased heart rate. So for an ectopic pregnancy, you want to make sure you monitor for signs of hypovolemic shock caused by hemorrhage. Remember, hypotension, tachycardia, restlessness, confusion. You will administer RhoGAM. Here's RhoGAM again within 72 hours to prevent isoimmunization. So that will protect the woman if she gets pregnant in the future. There's also a medication that we mentioned before. It's methotrexate. And this is given for ectopic pregnancies if the fallopian tube has not ruptured. So if the fallopian tube is not yet ruptured, methotrexate can be administered. And this is an anti-neoplastic drug, and it interferes with the cell multiplication, and it causes the embryo to stop growing and to reduce the chance of fallopian tube rupture. There are certain criteria that have to exist in order to use this drug. The fetus has to be less than 3.5 centimeters long. The fetus must not be alive, and the patient must be stable hemodynamically. If methotrexate is used to treat an ectopic pregnancy, the patient should avoid foods and vitamins with folic acid and alcohol because those will decrease the effectiveness of this medication. If the fallopian tube has ruptured, a linear salpingoscopy is performed to save the tube. A salpingostomy is a small linear incision made into the fallopian tube to remove the products of conception, and that tube is allowed to heal without a suture to prevent scarring. If the fallopian tube ruptured and is not able to be saved, or the patient might not desire a future pregnancy, the tube may be removed. So a salpingectomy is a surgical removal of the fallopian tube. So post those procedures, you always want to monitor post-op vitals according to your facility protocol. O2 sat, intake and output, monitor for vaginal bleeding, and assist that patient with psychosocial support. You know, she was going to be going through some emotions like guilt, sometimes anger, sadness, grief. It's all a part of coping with a pregnancy loss. Patient teaching for an ectopic pregnancy include notifying the doctor if she has any fever, chills, or significant bleeding. If she did receive methotrexate, that you educate her about common side effects of nausea and vomiting. Discuss with the patient about the grieving process and just let her know that that is extremely normal, and the time frame really just varies for each woman. Gestational trophoblastic disease is also known as a hydratiform mole or a molar pregnancy. You might hear it called that more often. Be familiar with all those terms. And this is a genetic abnormality that occurs during early placental attachment and fetal development. And this causes the placenta to grow and develop, but not the fetus. So the little villi of the placenta start to swell, and they form fluid-filled sacs like you can see in this picture up here. And they look like tiny little clusters of grapes inside the uterus. These fluid-filled villi can actually grow large enough to fill the uterus to the size of an advanced pregnancy. There are different classifications to a molar pregnancy. You have a complete molar where it completely fills the uterus, and a partial molar where the fetus or amniotic sac is present along with fluid-filled sacs. So it's important to note that with a molar pregnancy, the fetus is not viable. Signs and symptoms of a molar pregnancy include light to heavy bleeding, blood that may be brownish or bright red, uterine growth that is larger than expected for gestational age due to the, remember, the cluster of grapes that can become fluid-filled, the villi becoming swollen, absent fetal heart tones and movement, serum pregnancy levels that are increased, that's the HCG, the pregnancy hormone. They may have hyperemesis, and you may see gestational hypertension. Medical treatment for a molar pregnancy may include the drug methotrexate. So here's methotrexate mentioned again. This drug interferes with cell multiplication, and it works to help stop that hydatiform mole from continuing to grow, and it can prevent the patient from needing surgery to stop the growth of the molar pregnancy. Abnormal tissues are removed by vacuum aspiration or by surgical D&C to entirely empty the uterus. Hemorrhage is going to be a common complication after an evacuation of a molar pregnancy. So IV oxytocin or Pitocin is administered after the procedure to help contract the uterus and help control bleeding. There's another possible complication of a molar pregnancy, and it's called a choriocarcinoma. This is a fast-growing cancer that can develop in the uterus following a molar pregnancy. This type of cancer develops from germ cells, so they're cells that ordinarily turn into sperm or eggs. Choriocarcinomas resemble the cells that surround an embryo in the uterus. To monitor for malignancies, the patient will need follow-up care with serially monitored HCG levels for about 9 to 12 months, and she must avoid pregnancy during this time. Gestational trophoblastic malignancies are almost 100% curable. However, pregnancy will make it difficult to monitor for abnormalities. Nursing care for a hydatiform mole or a molar pregnancy are to assess for signs of hypovolemic shock. That's your low blood pressure, your increased heart rate, restlessness, confusion. Make sure that she is prepped, pre-op prep, if she is to get a surgical procedure. Here's RhoGAM mentioned again. You'll give RhoGAM to an Rh negative woman to prevent isoimmunization. You'll monitor post-op vitals per facility protocol, O2 sat, INO, vaginal bleeding according to institutional policies. You'll emphasize the support of consistent follow-up, but there is a small but real risk of developing malignant disease. Of course, your psychosocial support is very important to help her in her reaction to grief and loss. The next complication of pregnancy we're going to talk about is placenta previa. So placenta previa is the abnormal attachment of the placenta in the uterus near or over the cervical opening. The placenta normally attaches either to the top or the side of the uterus, not in the lower parts of the uterus or near or over the cervical opening. Some causes of the placenta attaching abnormally could be advanced maternal age, carrying multiples, if she's already had a baby, so in second-time moms, drug use like cocaine or smoking, and scarring in the uterus from surgery, whether it be maybe a fibroid removal or a C-section. Cases of placenta previa do vary, so treatment depends on how far along the woman is. Placenta previa can be seen on a 20-week ultrasound. Sometimes if the placenta is found to be low-lying, partially or marginal, the placenta will move upward away from the cervix as the uterus grows throughout the rest of the pregnancy. So they can reassess that with an ultrasound a little later on, like about 32 weeks or so. So in some cases, placenta previa can correct itself. As the pregnancy nears term and the cervix starts to dilate, bleeding occurs due to that placenta becoming unattached to the uterus, and that bleeding puts the unborn baby at risk. You know, since the placenta supplies oxygen to the fetus until after birth, if the placenta becomes unattached, the baby is not getting oxygen. So it can be very dangerous to the fetus after birth. So there's different forms of placenta previa. You have marginal previa, that's where the placenta is near the edge of the cervical opening. You have partial previa. That's the placenta partially covering the cervical opening, but it's not fully covered. And complete previa. That's the placenta completely covering the cervical opening. There's a really good video here on YouTube that goes over everything you need to know about placenta previa. I'll be sure to link that to your Blackboard for you as well so you can watch it, because I'm unable to play the video during this recording, but I would highly recommend it. It's a really good one. This is another really good video. I really love this guy's illustrations that he does, because this really shows you how in placenta previa, how that placenta is implanted very low in the lower uterus. And in this particular drawing that he did, it's completely covering the internal cervical os. So this leads to bleeding after 20 weeks gestation. And here he has the normal drawing just so you can compare and contrast. See how it's normally in the upper uterus. Well, in placenta previa, it's down low here. I want you to know the different risk factors for placenta previa, like having a previous C-section, drug use like cocaine use, also smoking, having a history of previous placenta previa, having uterine scarring, and a previous spontaneous abortion. A characteristic sign and symptom of placenta previa is this right here. It is painless, bright red bleeding that is visible. Here's a placenta previa mnemonic. So we have painless, vaginal, bright red bleeding. It could vary from mild to profuse. So that bleeding is occurring because the placenta is becoming unattached to the uterus. R for relaxed, soft uterus that is non-tender. So the uterus will be non-tender. This is in contrast to Abruptio placentae, which is another complication we're going to discuss. E stands for episodes of bleeding. This is not spotting, it is bleeding. Typically, it occurs during the 3rd trimester as the baby's preparing with the cervix thinning. So it's tearing the little blood vessels in the placenta and it's causing the bleeding. V for visible bleeding. It is not concealed, as in some cases with Abruptio placentae, which we'll discuss in here just a minute. I, intercourse. The woman should be very careful because intercourse can lead to further bleeding, and it can even send her directly into labor. A for abnormal fetal position, breech, which means bottom first, or transverse lie, sideways. A baby's head should normally be down, but the placenta is in the way, so a lot of times you have abnormal fetal position, with the fetal heart rate being normal. So that's a mnemonic device to help remember placenta previa. So you remember the word previa. For nursing care for placenta previa is pelvic rest. Instruct the patient to avoid vaginal exams. No vaginal exams, no sexual intercourse, pelvic rest. Avoid things like douches during pregnancy. You don't want to cause injury to the vulnerable placenta presenting at the cervical opening. No abdominal manipulation. And if the woman is experiencing no bleeding or very light bleeding, she needs to be on bed rest. No strenuous exercise, no sexual intercourse for the rest of the pregnancy until the baby is ready for delivery. If the woman is experiencing bleeding, she will likely have to be hospitalized to monitor the baby and the mom. She's at risk for hemorrhage, so she may need a blood transfusion, a type and cross match. Remember, if she's Rh negative, she's going to need RhoGAM to help prevent isoimmunization. She'll need IV access. She'll need an 18 gauge or bigger for transfusion of blood products and fluids. You'll monitor CBC and blood clotting levels. You'll apply an external monitor to monitor the baby's fetal heart tones. Monitor the baby's vital signs per protocol every 15 minutes or whatever your protocol states. Remember, low blood pressure and increased heart rate are signifying shock. Monitor amounts of blood loss. So, are there a lot of pads and linen soiled with blood? Make sure to place mom on the left side lying position. This increases the amount of blood and nutrients going to the baby via the placenta. If the bleeding can't be stopped, she will likely need a C-section. You'll want to teach her to perform a daily kick count. Report to the healthcare provider if it's less than 10 kicks in 1 hour. Fetal kick counts. So typically this is done when the baby is at least 28 weeks gestation, just because earlier on the baby is too small. It's much too early on. So once they reach 28 weeks, their movements are much more predictable, much more consistent. If the woman is a high-risk pregnancy or carrying multiples, you'll want to start doing kick counts a little earlier at 26 weeks. It's also recommended to monitor kick counts at the same time every day, just so you can get a feel for the baby's patterns and consistency. So you pick the right time of day and stick with the same time each day. Pick a time of day when the little one is more active. Typically that's during the evening. Assume the position. So you get into a comfortable position. She lies on her side and counts distinct fetal movements. See how long it takes the baby to move 10 times. You want the time, how long it takes for the baby to move 10 times. So usually they'll move 10 times in a 2-hour period. That's reassuring. If you can't feel your baby move 10 times within 2 hours at the usual time, wait an hour and try again. If she's still not feeling any fetal kit count, she needs to contact the healthcare provider right away just to be monitored further. If the baby's movements, just take note that they will increase in frequency and intensity as the pregnancy progresses. So inform the birth team if movements start to weaken or decline, and keep updated kit counts if they start to change. This is an alternate placenta Previa mnemonic that I found that you're welcome to use, whichever one works better for you. Placenta Abruptio, also called Abruptio placentae, is the detachment of the placenta from the uterine wall before the birth of the baby. It can be partial or total separation. So it's the premature separation of the placenta from the wall of the uterus. Bleeding occurs between the uterine wall and the placenta. So bleeding tends to be hidden with Abruptio placenta, whereas with Placenta Previa, bleeding is visible. So we mentioned how Abruptio placenta could be partial or complete. An abruption is partial if the margins of the placenta remained attached and a section detaches from the uterine wall. With a complete abruption, the entire placenta separates from the uterine wall. This is a life-threatening event for the fetus and the mom. A patient experiencing an abruption is at risk for severe hemorrhaging, resulting in hypovolemic shock, DIC, and death. The placenta provides oxygen to the fetus, so an abruption of the placenta can lead to a fetal hypoxia and death. So remember, the placenta is part of the baby's life support system. It transports oxygen and nutrients to the baby. So when the placenta separates from the uterine lining before labor, it interrupts that transportation of oxygen and nutrients to the baby. Risk factors for Abruptio placenta include abdominal trauma, hypertension, drugs such as cocaine and methamphetamines. Those drugs cause systemic vasoconstriction that can severely restrict the placental blood supply, that can lead to hypoperfusion and ischemia, or otherwise disrupt the vasculature of the placenta. It can cause tissue necrosis, bleeding, and therefore the abruption. Also with alcohol use and tobacco use, multiple pregnancies, having a short umbilical cord. Other risk factors are diabetes, advanced maternal age, and having a history of placental abruption. Placenta abruptio signs and symptoms. So notice here there's concealed bleeding with Abruptio placentae. That's different than Placenta Previa. So this concealed bleeding is staying inside the uterus, between the placenta and the uterus, and it can actually backflow into the fallopian tubes. The patient can actually enter shock without even being able to see the amount of blood loss. Severe uterine tenderness is seen, as well as a firm board-like abdomen. Very firm. That's caused by all the irritation of the abdominal muscles by the bleeding. You can see pain in the lower abdomen or lower back, and she'll experience uterine irritability and poor uterine resting tone. Abruptio placenta treatment. So the diagnosis is made on symptoms and abdominal ultrasound. Treatment's going to vary depending on the severity You're going to monitor the baby continuously with an external fetal monitor. Type in cross-match, take a CBC with blood clotting levels, RH factor. Remember, if she's RH negative, she's going to need the RhoGAM shot. She needs a large bore IV for transfusion of blood products if needed. Prep for delivery of the baby. So an emergency C-section may be required to save the fetus. A vaginal delivery may be attempted if the abruption is small and if the mother and the fetus are stable. So you're going to monitor frequent vitals, fetal heart tones, you're monitoring for blood loss, pain level, providing psychosocial support. You're there to report any bleeding to the healthcare provider, inform the patient that a C-section may be required, and just try to answer questions with clear and honest information. So this outlines some differences between Abruptio placentae with Placenta Previa. So Abruptio placentae is a detachment issue. It is where there is premature separation of the implanted placenta from the uterine wall. That's where the blood collects. Now with Placenta Previa, it's an attachment issue. It's an abnormal attachment of the placenta in the uterus near or over the cervical opening to varying degrees. Another thing I want to point out are the symptoms. So placental abruption, you have painful vaginal bleeding. It's very painful, whereas Previa is painless. With placental abruption, vaginal bleeding is not always present. Sometimes it's hidden. With Placenta Previa, you have bright red vaginal bleeding. Placenta Accreta is a serious pregnancy condition that occurs when the placenta grows too deeply into the uterine wall. Typically, the placenta detaches from the uterine wall after childbirth, but with Placenta Accreta, part or all of the placenta remains attached, so that can cause severe blood loss after delivery. So with the Placenta Accreta, the placenta is attached too deeply into the wall of the uterus. So it's very complicated to remove. Normally it releases very easily, but with Placenta Accreta, the placenta is adhered and it's not wanting to come out. So it's very difficult removal. Complications are hemorrhage and a possible hysterectomy. Risk factors for Placenta Accreta include abnormalities of the uterine wall. So if there's a lot of scarring, like after a previous C-section or a uterine surgery, a low implanted placenta, advanced maternal age, so women more than 35 years old, having a previous C-section, their risk is going to increase with each pregnancy. Also, uterine fibroids and cysts, like with women with PCOS, for example, polycystic ovarian syndrome. So ovarian cysts are fluid-filled sacs that form in or on the ovaries. Sometimes ovarian cysts do not cause symptoms and they go away fairly quickly, but some cases, large cysts may cause pelvic pain and may lead to this condition of Placenta Accreta, for example. Signs and symptoms, often no signs and symptoms during the actual pregnancy, so this is not diagnosed until childbirth. If there are symptoms during pregnancy, third trimester vaginal bleeding may be the only symptom observed. You might see a rise, an unexplained rise, in the level of alpha fetal protein that has been linked to Placenta Accreta. Alpha fetal protein is a protein normally made by immature liver cells in the fetus. Pregnant women carrying babies with neural tube defects may have high levels of AFP. So a neural tube defect is an abnormal fetal brain or spinal cord that is caused by folic acid deficiency during pregnancy. Medical care usually involves a C-section followed by a hysterectomy, depending on, the severity of the case. They may be able to avoid the hysterectomy. A hysterectomy is a surgical procedure to remove the uterus. So this prevents the woman from severely hemorrhaging, which could be very life-threatening for her. So nursing care are to prepare for a C-section. Depending on the severity, she may be able to have a dilation and curettage called a D&C, and that way she avoids having the C-section. But it depends on the severity of the case and what the doctor feels is best for that woman. So you're going to explain to the patient that there's nothing she could have done to prevent this. A C-section birth may be scheduled, so teach her about that. Encourage the patient to discuss surgical options with the physician, like a D&C versus a C-section. Explain that after the hysterectomy, she will no longer have menstrual periods or be able to become pregnant again. Care of the woman with Rh incompatibility between maternal and fetal blood. So earlier in this unit, we talked a little bit about this. It goes more into detail in this chapter. Rh incompatibility can occur during pregnancy if the woman has been exposed to fetal blood cells that are Rh positive. Rh factor is a surface antigen on a red blood cell. An antigen is any substance that causes the immune system to produce antibodies against it. Rh incompatibility. So this occurs when an Rh negative mother becomes exposed to fetal blood cells that are Rh positive. So it happens when an Rh positive father and an Rh negative mother have an Rh positive baby. The baby's blood will enter mom's circulation at some point, causing her to create antibodies that could attack the child's red blood cells. It mainly affects the child of the second pregnancy and onward because the antibodies were created in the first pregnancy. So the antibodies get created in that first pregnancy, and then if she becomes pregnant again and has an Rh positive baby and wasn't treated with any RhoGAM, she would have antibodies against the baby that would attack the baby's red blood cells. So these antibodies tend to be created after delivery of the first child, but there are some circumstances that the child of the first pregnancy could be affected as well. It's much more rare. So isoimmunization, this is a term meaning the Rh negative patient exposed to Rh positive blood, and that's where the immune system produces antibodies. So it's not a problem for the mom, it's a problem for the baby, in particular the baby of a second pregnancy. So why does it matter if the mom is Rh negative and the baby is Rh positive? So the big deal is that people who are Rh negative so the Rh factor is absent from their red blood cell surface, can only receive other Rh negative blood. They should never receive Rh positive blood into their circulation because the body will create antibodies, and those antibodies attack Rh positive red blood cells. However, a person with Rh positive blood can receive both Rh negative and Rh positive blood without any complications. So keeping that in mind, if the baby's blood, who is Rh positive, mixes with the mother's blood, who is Rh negative, the mother's body will create antibodies that will attack Rh positive blood. Hence, it will be attacking the baby's blood. And remember that Rh lives on the red blood cell surface, so it attacks the baby's red blood cells. So when does the mixing of blood occur, and why does this condition affect the child of a second pregnancy and onward? Well, the mixing of blood most likely occurs during delivery, like when the placenta is detaching. Therefore, the child of the first pregnancy is gone and not present for the antibodies to attack the red blood cells. It happens after the first baby's birth. Now, a child of a first pregnancy can be affected if the mother has some type of complication, traumatic experience, anything invasive, like she experiences abruptio placentae, or maybe she has an invasive procedure done, like an amniocentesis. In that case, she would have to get RhoGAM administered to her. So the baby would still be in the womb at that point, because that would be her first pregnancy in this scenario. So it can affect the first child if that Rh negative mama goes through some sort of trauma or invasive procedure like an amniocentesis. So if the mom doesn't receive her RhoGAM, if she gets pregnant again, her antibodies will attack her child's red blood cells, and that will experience hemolysis. That is the name for the red blood cell destruction that occurs from the antibodies. So that's going to lead to severe anemia in the baby. So when hemolysis occurs, you're going to see a lot of jaundice in that baby because the breakdown of red blood cells leak bilirubin into the blood, and the liver just can't process it fast enough. So bilirubin is that yellowish brownish substance that leaks into tissues. So the baby will take on a jaundiced appearance in that case. So the key with Rh incompatibility is prevention, preventing that mom from ever becoming sensitized in the first place. Sensitized meaning ever developing those antibodies against the baby's Rh positive blood. So signs and symptoms, there's no physical signs in the mother, but she will need to get this indirect Coombs test, and this is an antibody titer that's done to determine if the isoimmunization has occurred. Remember that isoimmunization just means that that mama has built up antibodies against the baby's blood. So when you have a negative indirect Coombs test, that's considered normal. So remember, as negative is normal. And that's telling you that that mama has not developed antibodies against that Rh positive fetal blood. So the baby's not at risk here. This is good. So RhoGAM is administered to this mom to prevent antibodies from forming. So we're preventing. Remember, preventative care is the best way to prevent this. We do not want her having issues in the future. A positive indirect Coombs test, this would be our abnormal finding. So it's just the opposite. It means that, sorry, my bad highlighting skills, y'all. It means that that mother's immune system produced antibodies against the baby's Rh positive blood. So in that scenario, the mother is evaluated at intervals, and it's determined the level of antibodies, like how much, and the well-being of the fetus is monitored very closely. So a positive indirect Coombs means that that mother has already produced antibodies. So in that case, RhoGAM is not effective with her because she already built up the antibodies. There's nothing RhoGAM can do to prevent that. So all of these slides about Rh compatibility are just super important. So when that mother's blood type is assessed, if she's Rh positive, she doesn't need RhoGAM. She's good. If she's Rh negative and her baby is Rh positive, she's going to need RhoGAM shot at 28 weeks gestation. So I want you to know, like, the instances when you would administer RhoGAM. So you would give her RhoGAM at 28 weeks, and then she would receive it again. I'm going to write this in on your slide here. She would receive it again within 72 hours after birth of the baby. So this is after delivery. So RhoGAM stops that immune system from creating the antibodies. It's given intramuscular IM if the mom, remember, if the mom already has those antibodies created, RhoGAM isn't going to be effective. It's not going to do anything for her. And make sure you understand that anytime there's an invasive procedure, like an amniocentesis, that, you know, the needle goes in, there's a risk for mixing of the mama's blood with baby's blood. So she would need to receive RhoGAM as well. So you would want to administer RhoGAM after any type of abortion, and I'm talking about spontaneous or planned abortion, chorionic villus sampling, amniocentesis, any sort of trauma, and at 28 weeks gestation. And there's that key point about the 72 hours. So you want to make sure that Rh negative mom is compliant with all requests by the healthcare provider if the blood test determines that she's going to need RhoGAM. So as far as patient teaching, you need to explain to the woman that it's not a risk for her as the mom, but it's a potential problem for the fetus. So it needs to be really taken seriously. Teach her how RhoGAM works, about preventing the formation of antibodies. You know, teach her about what can happen to the baby if she doesn't get ROGAM. It could be hemolytic anemia that causes the breakdown of the RBCs. So explain the purpose and stress the importance of it at 28 weeks gestation and within 72 hours of childbirth, and also after any invasive procedure or any like traumatic complication that could cause mixing of the blood. Multiple gestations are becoming more common in women that use fertility treatments to get pregnant, as those can result in multiple gestations. There's an increased risk for multiples if the mother used fertility drugs, if she's of advanced maternal age, if she has a family history of multiples, or if she used assisted reproductive technologies to become pregnant, such as in vitro fertilization. Signs and symptoms are rapid weight gain in the first trimester, intense nausea and vomiting because of all of those hormone increases, extreme breast tenderness. Medical management would be increasing her calories, making sure she has a well-balanced diet. So the American College of Obstetricians and Gynecologists recommends women carrying multiples twins to gain at least 35 to 45 pounds. So mothers of multiples need more calories, protein, and nutrients. She needs frequent prenatal visits. So frequent visits to the doctor to help prevent complications. We want to detect complications early. Increased rest. So she may need more rest or even bed rest if complications develop. Multiple pregnancies often require bed rest beginning the middle of the second trimester. She may need a referral for special testing if needed. She may need testing to monitor the health of the baby, or like a biophysical profile that we talked about in one of the previous chapters, and monitor for complications, which could be incompetent cervix, preterm labor, preeclampsia, which we'll discuss here in a moment, gestational diabetes, placental abruption, a baby small for gestational age, and increased risk for needing a C-section. So with patient teaching, teach her all about her healthy diet, to be alert for signs of preterm labor, like contractions, cramping, low backache, increase in vaginal discharge, loss of the mucus plug, and pelvic pressure. Teach her to be compliant with all of her office visits because chances are she'll have to be seen more often. Teach her to schedule rest periods and to report any increase in edema, headaches, visual disturbances. That could be a sign of like preeclampsia, which we'll talk about in a minute, and report any vaginal bleeding to her doctor. Pregnancy-induced hypertension. So there's a range of hypertensive disorders that can complicate a pregnancy. The hypertension disorders fall under the umbrella term of pregnancy-induced hypertension. So this slide lists some different pregnancy-induced hypertension disorders. We're going to be talking about these on the following slides. We'll talk about the different hypertension disorders in just a moment, but I just want to mention that these hypertension disorders are multi-system diseases. So they're typically specific to the second half of the pregnancy, and they target organs in the brain, the kidney, liver, lungs, the heart, like the cardiovascular system, as well as the placenta. Chronic hypertension is referring to patients who are hypertensive before pregnancy or who become hypertensive during very early pregnancy. Frequently, the hypertension is related to obesity or having a strong family history of hypertension. There's many young women out there that do not receive routine health care until they become pregnant. So they may be diagnosed with hypertension at the first prenatal visit. Signs and symptoms of chronic hypertension include a blood pressure of 140/90 millimeters of mercury or greater before pregnancy, or that occurs before 20 weeks gestation. And chronic hypertension does not go away after pregnancy. She's going to need increased doctor checkups, a low sodium diet for sure, antihypertensive medications, and that's antihypertensive meds that are safe for pregnancy. Nursing care involves monitoring her blood pressure, administering those meds, and monitoring her, teaching her the signs and symptoms of preeclampsia. What could happen if this is allowed to get out of control? You're going to provide patient teaching. You're going to teach her to rest on her left side to increase the placenta blood flow. It also promotes diuresis, so it'll help get some of that excess fluid out, which will in turn help lower blood pressure. Teach her to drink 8 glasses of water a day to prevent dehydration and a low sodium diet. Consume a daily diet of high protein and high fiber. Give her antihypertensive meds. Check her blood pressure and urine for protein. Check daily for her fetal kick counts. Record weight daily. And instruct her for signs and symptoms of preeclampsia, which we'll talk about in just a moment. Gestational hypertension. This is elevated blood pressure that occurs in pregnancy, and it can lead to preeclampsia if it's not treated. So for signs and symptoms, if it's a blood pressure of 140/90 millimeters of mercury or greater for the first time during pregnancy. So it occurs for the first time during pregnancy. Blood pressure returns to normal less than 12 weeks postpartum or so, and there's no protein found in the urine, as with preeclampsia, which we'll discuss in just a minute. All the interventions are just the same that we talked about for chronic hypertension. This mama will also need increased frequency of prenatal checkups. Now we're going to talk about the complication of preeclampsia. So preeclampsia is defined as hypertension and proteinuria, meaning protein in the urine, after 20 weeks gestation. So it's characterized by high blood pressure and signs of damage to another organ system, most often the kidneys or the liver. It usually begins after 20 weeks of pregnancy. So signs and symptoms can be mild or severe. Mild preeclampsia, this is hypertension on 2 occasions at least 6 hours apart. Severe preeclampsia, this is a systolic BP of 160 or higher, or a diastolic BP of 110 or higher on 2 occasions at least 6 hours apart. With severe preeclampsia, You also see proteinuria of more than 5 grams in a 24-hour collection, or more than 3 plus on 2 random samples collected at least 4 hours apart. You could see pulmonary edema or cyanosis. Oliguria, this is 400 milligrams or less in 24 hours. Persistent headaches, so she'll have really bad headaches, epigastric pain. You might see impaired liver function, so some of the liver enzymes might be messed up on the lab work. Thrombocytopenia. And remember, thrombocytopenia is a condition where you have a low blood platelet count. She might have visual disturbances like blurred vision and dark spots, and you will see a lot of edema. So treatment is based on the patient and the severity. The goal is to control hypertension, to prevent seizures, to prevent long-term complications. Childbirth is the treatment for preeclampsia. The symptoms start to decrease soon after birth. The fetus should be monitored for maturity and labor-induced as soon as it's appropriate for the fetus. Also, she might need to be on bed rest for a while if she's not ready to give birth for the baby. So, for mild preeclampsia, she might be allowed to do bed rest at home. You'll see them checking a lot of labs like CBC, liver function tests, and platelet levels. If the patient has severe preeclampsia, she will be hospitalized, where they're going to do a daily urinalysis. They're trying to look for protein in that urine, and they're measuring her weight daily. And I want to go over why proteinuria occurs with preeclampsia. So with pregnancy, your kidneys are really hard at work. They're working overtime during pregnancy. They filter the waste products in the blood, all while keeping things like protein that your body needs to thrive. So after being filtered, the waste products are released into the urine. So if protein makes its way to the urine, it's usually indicating that something is not functioning quite right in the kidneys. So if she has severe preeclampsia and needs to go to the hospital, magnesium sulfate is given to prevent seizure activity. And magnesium sulfate is super important. You'll see this medicine a lot, and Clux loves to test on that one as well. And there is a really good table in your book that I'm trying to find here. Okay, it is on page, I'm going to write this on here for you. Page 96. And it's in the little drug facts box. I'm going to cover more in detail about mag sulfate a little bit later in this slideshow. So this is a mnemonic device used to remember the preeclampsia, the 3 classic signs, and that's P for proteinuria, R for a rising blood pressure, and E for edema, particularly in the face and the hands. It's often pitting edema where the swelling still stays indented when pressed on. Now we're moving on to eclampsia. So eclampsia, I want you to remember this definition here. It's an onset of a seizure with the diagnosis of preeclampsia. So essentially, you can remember preeclampsia plus seizures equals eclampsia. Signs and symptoms are the same as preeclampsia, except you add seizures before or during labor or after delivery. Medical cares with mag sulfate, we'll cover more in detail about that in just a moment. She's also going to receive IV fluids and antihypertensive meds, and you're going to plan either a vaginal or cesarean birth after the seizures are controlled and after she is stable. So for nursing care, you want to do your seizure precautions, protect her during the seizure, clear the airway, administer oxygen, and provide for her safety. Document the description of the seizure, the length, the nursing care you provided during, and then after the seizure, reorient her. Provide emotional support for her and her family, because that can be extremely scary. And then do your postpartum management. So you're going to monitor her blood pressure, her reflexes, urine output, and look for any protein in the urine. Eclampsia can occur up to 48 hours after delivery. And I just want to mention that I know I talked about assessing her reflexes. We'll talk about that in just a moment as well when we talk about mag sulfate. HELLP syndrome is a cluster of symptoms. It's a potentially life-threatening disorder, usually associated with preeclampsia. So that's a condition that occurs in about 5 to 8% of pregnancies or so. And it's most often occurring after the 20th week of pregnancy. HELLP syndrome is a disorder of the liver and the blood that can be fatal if left untreated. The symptoms of HELLP syndrome are wide-ranging and vague, and they can be often difficult to initially diagnose. The name HELLP syndrome is actually an acronym of the 3 major abnormalities seen on the initial lab analysis. These include hemolysis. This refers to the breakdown of the red blood cells. So they get broken down too soon and too rapidly, and it can lead to anemia. It can also lead to jaundice, since bilirubin's a byproduct of red blood cell breakdown. Elevated liver enzymes, that's the EL, indicates that the liver is not functioning properly. Inflamed or injured liver cells leak high amounts of certain chemicals, including enzymes, into the blood. LP stands for low platelet count. Platelets are components that help with blood clotting, so when the platelet levels are low, your patient's at increased risk for excessive bleeding. HELLP syndrome is a rare disorder. It affects less than 1% of all pregnancies, but it's a major health concern, and it can be life-threatening to both the mom and the unborn baby. Prompt treatment and delivery of the baby are generally required for the best outcome. HELLP syndrome usually develops in the last trimester of pregnancy, but it can occur earlier or even postpartum. Medical management is to deliver the baby as soon as possible, and it may need to be done via C-section. You're going to give antihypertensive meds and mag sulfate. We'll cover details of mag sulfate in a moment. Possible complications are disseminated intravascular coagulation. So that is an abnormal blood clotting disorder, pulmonary edema, kidney failure, liver failure, and abruptio placenta. You want to monitor for blood pressure and her urine output, fetal monitoring as well. Magnesium sulfate. So the method of action is that it blocks neuromuscular transmission. It's given to prevent seizures because it depresses the central nervous system. So a typical dose is 4 to 6 grams in 100 mils of fluid, given IV over 15 to 20 minutes, followed by a maintenance dose of 2 grams as a continuous infusion. I want you to remember the antidote. Anytime there's an antidote for a medication, NCLEX loves to ask questions about that. So calcium gluconate is the antidote for magnesium sulfate toxicity. We'll talk more in detail about that here. That is this little acronym here, BURP. So with magnesium sulfate toxicity, you can see a low blood pressure, decreased urine output, decreased respiratory rate, and absent patellar reflexes. These are some nursing considerations that you definitely want to consider before you administer this med. You want to assess the patient for a respiratory rate of at least 12 breaths per minute, an O2 sat of 90 to 5 degrees or higher, percent or higher, a urine output of at least 30 mils an hour, and they need to have deep tendon reflexes present. If their reflexes are absent, no additional doses are given. If their respiratory rate is not at least 12, you will not give it. If their O2 sat is not 95 or higher, you will not give it. It's very serious. If they don't have enough urine output, you will not give it. You must administer this on time with the correct dosage. You have to have a second nurse check with you. Accidental overdose can result in serious harm for this patient. So you want to monitor for signs of mag sulfate toxicity. This is hypotension, depressed deep tendon reflexes, flushing, drowsiness, and decreased respirations. Reflexes are graded on the deep tendon reflex rating scale. So an absent reflex is 0, hypoactive 1+, normal 2+, slightly above average 3+, and hyperactive 4+. So anything abnormal, you're going to report. Like you would report if it's absent for sure, and you would want to document and report if it's above average or if it's hyperactive. Assess for clonus, and this is a vocab word to know, where you need to support the patient's lower leg with the hand, and it's like clonus is like involuntary rhythmic muscular contractions, and they increase the risk for seizures. So you need to dorsiflex the foot to help stretch that Achilles tendon. Hold that flexion. If the clonus is present, you will observe a rapid tapping motion of the foot. That indicates hyperreflexia. You're going to report that to the doctor. And it's important to note that hyperreflexes, that is known to occur in many women prior to seizures. So if they have hyperactive reflexes, it could be a sign that a seizure is about to occur. Care of the woman with gestational diabetes. So this is a blood glucose level elevated during pregnancy, but the patient is not previously diagnosed as a diabetic. It's often caused by insulin resistance. Risk factors can be age greater than 25, physical inactivity and being overweight, having a history of gestational diabetes with a prior pregnancy, previous birth of a baby weighing more than 9 pounds, unexplained stillbirth, being of African American, Native American, Hispanic, or Asian descent. That's a risk factor. Having prediabetes, a condition in which the blood glucose is higher than normal, but it's not high enough for an official diagnosis of diabetes. Having a family history of type 2 diabetes, and having polycystic ovary syndrome, or PCOS. They have insulin resistance as a sign and symptom, so it puts them at risk. Signs and symptoms are your same signs and symptoms with hyperglycemia, your 3 Ps, your polyuria, meaning increased urination, polydipsia, meaning increased thirst, and polyphagia, meaning increased hunger. Current recommendations are that high risk for gestational diabetes women should be identified at first prenatal visit and screened at that time with a 2-step glucose tolerance test. All pregnant women should receive an oral glucose tolerance test between the 24th and 28th weeks of pregnancy, and that's to help screen for the condition, regardless of whether she's tested non-diabetic at a previous screening. So she also, in addition to her routine pregnancy labs, she should also have the following tests to monitor for possible complications. Hemoglobin A1C, that's kind of like a 3-month average blood sugar. A BUN, serum creatinine, her TSH and T4, and her capillary blood sugar levels 2 to 4 times daily. She needs to be monitored for diabetic ketoacidosis. That's an accumulation of ketones in the blood because of high glucose levels. So in pregnancy, there's a state of accelerated starvation, especially in the 2nd and 3rd trimesters. The fetus and the placenta use large amounts of maternal glucose. So that leads to decreased maternal fasting glucose. So it makes them need more and more glucose. Along with insulin deficiency, this leads to an increase in free fatty acids, which are converted to ketones in the liver. In gestational diabetes, diabetic ketoacidosis can occur at blood sugar levels of 200 or more. Signs of DKA are increased urine production, increased thirst, nausea, vomiting, abdominal pain, weight loss, having hyperventilation and ketone breath, that's that sweet smelling breath, tachycardia, hypotension, dry mucous membranes, disorientation, and coma. You're also going to monitor for a large for gestational age fetus. So a lot of moms with gestational diabetes give birth to a larger infant. You're going to take her blood glucose measurements. So remember, the normal blood sugar range for a non-diabetic is 70 to 120. These are your target blood glucose levels for women with gestational diabetes. You can take a look at that in your book on page 101. You want to teach her about her diabetic diet and any medication she might need, like insulin, which is considered the standard treatment for the management of diabetes in pregnancy. Oral anti-hypoglycemic meds can also be prescribed.